Excellent morning to all participants on this call. I am very delighted to have you this morning. I welcome all retired heads of service and permanent secretaries on this call. Retired directors, I welcome you all, and all participants. Serving officers, I welcome you all. I'm glad to have you on this call this morning. Incidentally, there is a JNC going on, Joint Negotiating Council meeting. So the head of service will not be available this morning with us. And likewise, the Permanent Secretary, Public Service Office, Mrs. Sukomi Oyegbola, she will also not be available. I am also part of that meeting, so I'll be going off and on, but I'm sure we'll have a good time on this webinar this morning. This morning, we are going to talk about a very important topic, cerebrovascular accident, which is also known as stroke. This is a situation, a medical condition that makes blood not to flow into the brain, or maybe when a blood vessel ruptures. It is always important for us to know when we are developing this condition so that we can quickly seek and ensure we get medical help. So without wasting much of our time, I'm going to introduce our facilitator for today, who is from Luth, and then we'll go right into it. Our facilitator is Dr. Ogundare Adewale, who is a senior registrar in Department of Internal Medicine, Lagos University Teaching Hospital, Luth. He is currently the acting chief resident. He had his medical training in prestigious University Ladoke Akintola University of Technology, Ogbomoso, Oyo State. He did his 1-year compulsory medical internship at the Lagos State University Teaching Hospital, where he is currently undergoing his residency training. He is happily married with children. Welcome with me, Dr. Ogundare, who will be facilitating this session. Dr. Ogundare, you have the floor. Please unmute and continue with your presentation. Please unmute and go ahead with your presentation.
Good morning, Ma. Thank you very, very kind introduction. Good morning, everyone, and thank you for being here. Yes, good morning, Ma. So permit me to share my screen.
Yeah, go ahead, sir. You can share your screen.
Okay, Ma. Yes, I'm doing that right away. Okay, so like our moderator has said, we'll be talking about stroke or cerebrovascular accidents, like she rightly mentioned. If you look at the screen, I'm sure you see the image of someone who is attempting to run a race. So we have a maxim, which we normally use, especially when it comes to stroke. We say time is brain. And this is important. And I think we will understand more as we go on with the presentation. So I'll be using this outline. There would be introduction, a brief epidemiology, classification of stroke. I would mention the risk factors, talk about the clinical features, how we make a diagnosis, a bit about the treatment, and also talk about prevention of stroke. So stroke or cerebrovascular accident is defined as an abrupt onset of neurological deficit that is attributable to a focal vascular cause, including cerebral infarction, intracerebral hemorrhage, and subarachnoid hemorrhage, and is a major cause of disability and death worldwide. Okay, so what this definition is trying to tell us is that stroke is usually of sudden onset. So you have patients or individuals who present with sudden onset features of disturbance or affectation of the brain that is due to no other cause rather than the blood vessels, either as a result of these vessels being blocked or these vessels being burst open, like you mentioned earlier, leading to disability and death. So our brain cells are dependent on oxygen for their optimal function. So when anything happens to the carriage or passage of blood, which carries nutrients and oxygen to the brain cells die. And the problem here is that there are a few organs in the body who have the ability to regenerate, but the brain is not one of them. So if a part of the brain is lost, it is completely lost. And that leads me to the maxim again, which I mentioned earlier, that time is brain. So moving on to epidemiology, is the third most common cause of death in high-income countries. And in the United Kingdom, it accounts for about 11% of deaths. It's also the leading cause of adult disability worldwide. And as with most things, don't let me say most bad things, quite a large percentage or most of the burden of most diseases is in the low to middle income countries, such as ours. And stroke rates have actually been found to be higher in Blacks and in Caucasians. So in the past, we used to say that heart attack, which has a similar development to stroke, meaning that the blood vessels that is supplying the heart gets blocked, is not common in this part of the world, because we know for a fact that we Blacks have more problems with vessels or blood vessels that is supplying the brain, which is why we have a higher stroke burden than the Caucasians. And that the Caucasians have more narrowing of the blood vessels, as well as more narrowing of the blood vessels supplying the heart. Although we are beginning to see quite a number of heart attacks in this part of the world too. And is the reason why we are beginning to see it is almost the same reason why we have a higher proportion of strokes in this part of the world. So moving on to what the incidence or prevalence of stroke is in Nigeria. A study done in 2019, a meta-analysis. So what they did was to pull different studies together and look at what the incidence of stroke in Nigeria is. And I found out that it's between 12 to 39 per 100,000 person years, with an average of about 26. And an interesting thing about it is also that it's higher in men compared to women. And that the pooled crude prevalence of stroke survivors, so those who have had stroke and who survive, is about 5.8 to 7.7 per 1,000 population. But the interesting thing is that the prevalence, that's the number of people who survive stroke, is actually higher in males than in females. So we know for a fact that when women do have strokes, they have poorer outcomes compared to males. And the number of deaths that is attributable to stroke in Nigeria per year is estimated to be about close to about 300,000 annually. That's about 120 to 240 per 100,000. And this is even an old data. I'm sure the mortality rate would have increased by now. So what types of strokes do we have? Simply put, we have two major types. One in which the pipe carrying the blood vessel gets blocked. That's the ischemic stroke or infarction. And this accounts for majority of strokes that we see. So from things like narrowing of the blood vessels, deposition of fats, narrowing the lumen, breaking off of these fats, and formation of blood clots, blocking the flow of blood to the brain. So all of this can account for ischemic stroke. And then we have the hemorrhagic type, in which there is a break in the continuity of the blood-carrying pipes or vessels in the brain. What this does is that blood leaks into the brain itself. The way the skull is designed in such a way that as adults, there is no room for anything extra rather than what is in the skull in fixed amounts. So I'm talking about the brain matter itself. I'm talking about the fluid that bathes the brain, which we call the cerebrospinal fluid. I'm talking about the blood vessels and the blood flow into the brain. All of this is in a particularly tight, fixed amount, such that if anything else accumulates within the skull, it becomes a problem. And that's the major problem with hemorrhagic stroke. So because the pipes carrying the blood burst, blood seeps into the brain, and there is no space for it to take. So it simply compresses the brain tissue, and sometimes it can be severe enough that it actually pushes the brain matter through holes that are present at the base of our skull, and this can result in disability or death. So what are those things that increases the risk for individuals developing stroke? Age is one of them. So we know that with advancing age, the risk of stroke is higher. Sex, like that statistics from Nigeria showed, stroke is actually commoner in males, but females have poorer outcomes when they develop strokes compared to males. So race, which I had also talked about, is commoner in Blacks and in Asians compared to Caucasians, because we have more affectation of the blood vessels that is supplying the brain. Genetics. So there are some hereditary factors that have been found to be associated with increased development of strokes. So we call all these risk factors non-modifiable because there is nothing we can do about it. We cannot reduce our age. Well, people have made attempts to change sex nowadays, but it still doesn't remove the genetic, what's the appropriate word to use now, or the biological sex of the individual. We can't do anything about our race, and we can't do anything about our genes as well, which is why they are referred to as the non-modifiable risk factors. The other sets of risk factors are the modifiable risk factors. They are modifiable because they are things that we can do to control or to limit the possibility of developing strokes from these risk factors. Okay, I should also stress that because there are risk factors, it doesn't mean that everybody who is hypertensive will develop stroke. No. But we know for a fact that majority of people who have uncontrolled hypertension for a long period of time are likely to develop strokes as a result of changes to those pipes carrying blood from the elevated blood pressure that is passing through them. So the most significant risk factor for development of stroke is actually hypertension. And as the level of blood pressure increases, either the one on top, which is the systolic or the diastolic, is actually has been found to be associated with the risk of developing of stroke. Having diabetes mellitus is also a big risk factor for development of stroke. Smoking has so many deleterious effects. And because of some of its effects on these blood vessels, also increases the risk of development of stroke. Hyperlipidemia or elevated cholesterol also is a major risk factor for development of stroke. Being overweight or obese is a risk factor. Alcohol and substance abuse. So if I have a 21-year-old student brought into the emergency with features of stroke, one of the first things that would come through my mind is to make sure I rule out alcohol or substance abuse, particularly substance abuse, by doing a toxicology screen. So we know for a fact that these substances also can result in development of stroke, as some of them leads to markedly elevated blood pressures, which can lead to blood vessel rupture and development of stroke. People who have heart conditions, maybe from hypertension, maybe from other causes, also are at risk of developing strokes, especially when there is blood clot formation within the heart. Because the heart supplies blood to every part of the body, sometimes this clot within the heart can move through the pipes supplying the brain, lodge in the blood vessels, resulting in almost complete obstruction or blockage of these pipes carrying blood to the brain, resulting in stroke. We also know that certain infections also predispose to possibility of developing strokes. This includes tuberculosis, this includes acquired immunodeficiency virus, HIV, syphilis, and the rest of them. So these are not all, well, these are some of the most important modifiable risk factors for stroke. Moving on to clinical features, how does stroke present? So because we said that this is primarily a problem of blood vessels that is supplying the brain, and this leads to reduction in supply of oxygen and nutrients to the parts that particular blood vessel is supplying. So the clinical features depends on which side of the brain that the particular blood vessel involved supplies. So that's what determines the manifestation of strokes. But I'm sure almost all of us here have either seen or heard about patients who have strokes. And I'm sure the commonest presentation we know is the not being able to move either the hand or the leg, or both the hand and the leg, not being able to speak properly, the mouth deviating to one side. Yes, those are the very, very common presentation of stroke. But there is so much more that we see in day-to-day practice. So there are instances of sudden collapse at work. Somebody was seen healthy the day before, even the morning. He was just at work doing his usual daily activity and suddenly slumps. Okay. So, when I was talking about the definition, I said sudden onset, which is very, very important when we think about stroke. especially when patients present unconscious in the emergency. So what we are told, the history, is actually very important before we are able to get, of course, a brain scan to make a definitive diagnosis. So it is expected that the general public and paramedics can make a diagnosis of stroke using this acronym, FAST. The F stands for face. So when there is sudden weakness of one side of the face. So like I said, how will this manifest? It will manifest by the mouth being pulled, the angle of one mouth being pulled to the other side. So because one side is weak, the side that is strong is able to pull the other side towards itself, which is what actually gives that appearance. Arm or the limb. So sudden weakness of one arm or limb is also something that should make us think of stroke. Difficulty speaking or slurred speech, which is quite common, is also something that should make us think of stroke when people present with this in the community. And then lastly, the T stands for time. So the sooner treatment is started, the likelihood of a better outcome is quite increased. How do we make a diagnosis? So like I said, we want to know what surrounded the onset of either the weakness of one side of the body, the weakness of the face, loss of consciousness or loss of consciousness. So we want to know what happened, and that is the history. We want to know what happened before the onset of those symptoms. So has this person been complaining of headaches, which can be important, and did this person vomit? That is also important. Did this person have convulsions? That is also important to us. So those are the important things that we ask when people present with stroke. We also look for risk factors because there is usually no smoke without fire. Is this person hypertensive? Is this person diabetic? Don't forget that we would have started from the age. Of course, we know this person's sex. We know the race. So looking back at those non-modifiable and modifiable risk factors, those are the things we look at when we are making a diagnosis, because as much as possible, we try to find out what the risk factor is, so that if there are modifiable risk factors, we control, and that's one way of preventing a repeat stroke in that individual. Okay, and then I talked about brain scan, very important. So usually it's advisable that within 1 hour of the person presenting in the hospital, we should have a brain scan done. So this would show us features which I would show later of stroke on a brain scan. Blood test, a lot of them. So in our environment, we find out that most people don't present early to the hospital. Maybe because they can afford the healthcare, maybe because of so many misinformation in the past, like you don't give patients with stroke injections, it will make them worse. They will die if they go to certain hospitals, that people go there to die. So a lot of misconception, a lot of social issues as well. So we find out that most of the time our patients present 3 days, 4 days, even more after they have developed stroke. And not just the stroke, they have even developed complications before presenting to us at the hospitals. And this usually gives rise to outcomes that are not desirable if patients present that late. And in climes where things work, especially for the ischemic stroke type, in which the pipe carrying blood gets blocked, if an individual presents within 4.5 hours of the stroke, the person has a likelihood of better outcomes if the clot is broken down. So there are medications that can actually break down these clots. But first, we have to be sure that there is no increased risk of bleeding in this individual, because it breaks down clots. There is also possibility of making the individual bleed. So there's quite a list that we go through before we say, oh, this person will benefit from this treatment. or not. So when we say time is brain, 4.5 hours is that golden period. If it is the ischemic type in which the pipe carrying blood gets blocked and presentation to an hospital where there is facility. And these medications that I'm talking about are actually not cheaper. They are between 500 to 1 million naira for the dosage that is required to actually lyse these clots. And it's not even readily available. We have to contact the pharmaceutical company who is importing the medication. Then we will now find a way to get it across to you. And all of this is expected to take place within 4.5 hours. So even the logistics of sorting it out sometimes may not fall within that golden period that we actually need it. So blood tests, so blood sugar, very important. This is one of the most common tests that we do because we know that high blood sugar in patients with stroke is not good. So we try to bring it down. We check the kidney function. We check propensity for bleeding. So we do what we call clotting profile to be sure that the person does not have propensity to bleed. Then, like the genetic things that I mentioned about in people who develop strokes in which the pipes are blocked, some people have a genetic propensity to form clots. So all of this can be screened for. And then the ECG and echocardiography here is for us to look at the heart because, like I also mentioned, people who have heart diseases from different conditions also are susceptible to development of stroke. So this is a CT image just to show us what stroke looks like. Okay, so this is the brain tissue. This is the brain tissue. Yes, this is the skull that is white on the outside here. You know, like I said, you can see how thick this is, and this is bone. So it doesn't give space for any form of expansion for any other thing inside this rigid case that is protecting our brain. Okay. If you look at this image very well, so the way because when we have relatives who come with patients with stroke, we try as much as possible to even show them on this image what we are seeing, the sites where we believe the stroke is. So usually what we tell them is to look at, just imagine there is a line in the middle here dividing the brain into two hemispheres. Okay, the right here, the left here. Whatever it is you see here, you should see a corresponding image here. So we can see a dark area here, which is not on this side. So this person has a stroke on the right side of the brain here. And this is the type where the pipe carrying the blood to the brain is actually blocked. This is also an image showing the same thing, but showing a larger area of the stroke. If we look at the two sides, dividing it into two, we'll see that this place appears darker than this side. Okay, so this is what it looks like. This is what we see when we order for a brain scan. So this is an image showing the type in which the blood carrying vessels actually bursts, like just our pipes carrying water in the house burst, and then water is spilled all over the place. But just imagine this is a confined site where there is no space for it to flow to. So you can see here, it's quite obvious. This is one of the commonest sites where we have such bleeds in the brain. So you can see this very white area. This is blood in the brain. Okay, we can also see it here. It's much, much larger. Okay, so this is the hemorrhagic stroke subtype. Okay, so moving on to management. So how do we manage stroke? I think for this audience, what I would say is, like I've said earlier, time is brain. Most important thing is to, if you're able to identify the presentation using the FAST acronym, sudden weakness of the face, sudden weakness of the arm or limb, speech or language impairment, then the next thing is time. We need to get the person So an healthcare facility, that's the most important thing, so that treatment can start early for possible good outcomes in these individuals. So how we manage stroke depends on the stroke subtype. There's something I would also like to mention, which I have touched on earlier. So when we have the ischemic subtype in which the pipes carrying blood is blocked, we definitely have an area of the brain that is dead, that there is nothing anywhere in the world. Nothing can be done about it. Nothing can be done to revive that particular part of the brain. But we also know that what we see on the brain scan is not the entire picture. We know that there are some surrounding area around that place that is completely dead that can be salvaged, which is what our emergency treatment does. So what we try to do is to limit the area of damage in the brain so that the person does not have plenty deficits, to minimize deficits and then to minimize complications as well. So there are so many things, medical and surgical, that we do for patients with stroke. One area I would like to talk about is the aspect of feeding. So sometimes we know that patients with stroke have difficulty swallowing. And when they are fed,
we're sorry about that. I think our facilitator is having a bit of a technical glitch or internet issue. Oh, sorry about that. I think we lost our facilitator there, but well, we'll wait for him to come back. But while we wait for him, I want to sorry about that. I want to use this opportunity to recognize a retired PS, former Honorable Commissioner in Lagos State that joined us, Mrs. Florence Okuntuwashi, while the program was going on. I also want to recognize the presence or the participation of the president of Alausa, Association of Lagos State Retired Heads of Service and Permanent Secretaries, Dr. Olubile, who is also on this call with us. Thank you for joining us. I know we have quite a number of doctors with us. Dr. Oduwole is also with us on this call. I recognize you, ma'am. Let me just invite one of them, maybe to say one or two things to us, and if we have questions, they can assist us. So I'm going to invite Dr. Oduwole to please unmute and fill in the gap for us as we wait for our facilitator to come in. Good
Thank
morning, ma.
you very much. Good morning, distinguished members. Please, so far, I am very, very happy with the presentation of the doctor. He has done very well. But my pertinent advice to everybody is that we should take care of ourselves. Most of us just believe that our bodies are like machines that cannot break down. And my suggestion is that even if you don't have a family doctor, at least try and get a SFIG where you can take your BP or go to your neighbor who is a nurse or anybody so that you monitor your well-being. And then maybe twice in a year, try and see your doctor, do all your profiles, and know how far you have gone, because stroke is not something to joke about with. Apart from the fatality, it's also a lifelong disability that it causes. And my advice again is that we should take very good care of ourselves. Thank you very much.
Thank you very much, ma. I think Dr. Gundare is back.
Yeah.
So please, Dr. Gundare, you have the floor. Please go ahead.
Okay, thank you very much. So sorry, lost power. And that was connected to my internet as well. Okay, I was just on my last slide. I was talking about management, and then I was talking about feeding, because I know that our mothers, particularly African mothers, believe that once a sick person is able to eat, then there is no problem. And this end up doing more harm than good, feeding a patient who has problems swallowing. And then this food or other materials goes into the lungs. And this kind of worsens the outcome in our patients who present to us, because they come with a chest infection by the time they are presenting to us. And that's an additional problem on top of the stroke. So all in all, it's very important when patients develop these symptoms to get them to the hospital as soon as possible. And then other parts of treatment, apart from medical and surgical, would include physiotherapy. So one of the things we do when patients or individuals coming with stroke and there is weakness of one side of the body, physiotherapy is one of the things that we institute early. This is to enable the person to regain some power. Some people recover it completely. And then for people with speech problems, there are also speech, language, and speech therapists who can help. Then the last thing I want to mention is on stroke prevention. I think Dr. Duwale, I don't know if I got that name right, actually had talked about very important aspects of stroke prevention in terms of making sure. So hypertension, like I said, being the most important risk factor for stroke, does not have any symptoms most of the time. So I've seen people walk around with blood pressure of 220, 120, and they just checked. Maybe they brought their kids to the hospital and they just decided to check their blood pressure. And then you find out that it's markedly elevated. And such persons, the next thing you hear is that I was fine yesterday and we had a collapse today, and that's the end. So the modifiable risk factors, we have to identify them early if we develop them. Hypertension, diabetes, all of this can be screened for. Cholesterol, we can work on our weight to reduce obesity and make sure that all of these are adequately controlled. So if they are controlled, the risk of developing stroke is markedly reduced. And then when we do develop stroke, also, there is what we call secondary prevention. So you want to prevent the person from developing another stroke. And so you also do the same thing. So you tackle the risk factors that were there before. So the person still has to have their blood pressure controlled, have to have their diabetes controlled, have to have their cholesterol under check, and a whole lot of other things. Thank you very much for listening, and sorry for the technical issues.
Thank you very much, Dr. Ogundare, for your short and very educative presentation. Like he did mention, at times with very high blood pressure, you may not even be aware. And stroke is something that can, you know, happen so suddenly, and then, it will just claim the life. On that note, I want us to just observe a minute silence for one of us in PSO that we lost, our public affairs officer, Mr. Febi Ogun. A week ago, we were in our public service week. He was walking up and down, and then suddenly he collapsed. That was it. He was taken to the hospital, and we lost him. It was a stroke attack. Let's observe a minute silence. A minute silence. May his soul rest in perfect peace.
Amen.
It's question and answer time. So if you have a question, please, you either signify, I invite you to ask your question, or you type your question on the chat. I can see that a retired permanent secretary, public service office, Mr. Samson Ajibadi, is signifying. Please, can you unmute, sir, and go ahead with your question?
Good morning.
Good morning,
Good morning.
sir.
Uh-huh.
Good morning, sir.
My question is, considering the rate at which some of our officers suffer from stroke, what recommendation, we can through this platform, what recommendation can your office make to the office of the head of service to the governor concerning the well-being of civil servants? We are talking of checking the BP. Shouldn't there be a deliberate effort to ensure that quarterly, at least quarterly, they do this around the states, or ministries having enough gadgets, and the doctors will come or the nurses come and check the BP to save us from all this? And secondly, what can we do to prevent this apart from checking BPs? Does it have anything to do with our diet? With our diet? At times we hear when you exercise a lot, when you do this one, you did it, but we still see people who are very agile, who exercises a lot, still suffering from stroke. So I want the doctor to enlighten us on that and tell us what else can we do. Do intake of water regularly, detoxification, all those things that we are hearing there and there, can they really be of any value to us? Thank you.
Dr. Ogundare, you can please go ahead with your response to that question. I think we lost him again. He's no longer there. But I think Dr. Oduwole can help us. Please unmute ma and assist us with
Thank you very much, Mr. Jibade. I think there was a time this was being done, maybe yearly, and most civil servants were not really turning up in the hospitals. There was something there for people to just walk in and do their comprehensive tests. So I would want to say that it should be resuscitated again. And most of us, like I said, we must take our destiny in our hands. the government cannot run after, be running after us. We should make sure that we take good care of ourselves. And that anybody who is not feeling too good should go to, there's a clinic. And I tell you that staff clinic is still one of the best I have seen, because I've been there too. And we should take the opportunity of being able to go there, do whatever we want to do, and then come out. We are not babies. We know ourselves, and we should take good care of ourselves. I asked for the diet. Yes, it has a lot to do with it, because some of the things we take are not really what we should be taking. So recently, some people were saying that maybe they should review our African diet. But there is no way we can review our cassava and everything. We are used to it. But the portioning is what we can review. We can have sessions where the nutritionist can come and talk to the house generally on how to portion our food and how to make sure that we take the necessary food that will be ideal for us. And then weight loss is very important too. It's been associated with stroke, and people should take it seriously too. And exercising too. People go for exercises, but before you go for your exercise, for goodness sake, know your numbers, as we always say. Know your BP, your blood pressure, because if your blood pressure is already high and you go for exercise, a lot of people slump and they die like that. So I would suggest that the government should resuscitate it. People should have the quarterly or whatever. Yearly, even the yearly, people were not coming that time to the hospital. So this can be resuscitated, and we can be more informed with our feeding and healthy lifestyle. Thank you.
Thank you very much, ma. So I think the doctor is the facilitator is back.
Okay.
All right.
Yeah. So
there are questions on the chat as well, so you can take some of them as well. Somebody is asking about that person said you should throw more light on how safe it is to take vasoprene daily as part of preventive measure to stroke when you are maybe above 60.
Okay. So thank you very much, ma. Let me take that second question first. So
and then on the cholesterol too, you can just take all of them together.
Okay.
Somebody is also asking about what you can do if you have high cholesterol. How do you return it back to normal?
Okay, all right.
Go ahead,
so
sir.
I will start with the aspirin question. So in the past, we routinely prescribe aspirin for all patients who are hypertensive. But we stopped that practice a while ago because we noticed that when they develop hemorrhagic stroke, that's the type in which the individual bleeds into the brain, especially if they have uncontrolled blood pressure. They might bleed a bit more because what aspirin does is to prevent what we call platelet aggregation that is needed for clot formation. So, but for secondary prevention, which is what we use it for now, that is the person has had the ischemic stroke before. It is one of the most important interventions that we do to prevent the person from developing another stroke. So in short, it is quite safe. But for people who do have peptic ulcer disease, we give them a substitute because of the ulcer, which is clopidogrel. And then we also make sure that depending on when the stroke occurred, so after a while, say maybe 2 weeks to 1 month, we reduce the dose. Initially, in the immediate stroke period, we give them as high as 300 milligrams a day. But as time progresses, we reduce the dosage to safe amounts, say between 75 to 150 milligrams a day. And for people who cannot tolerate aspirin because of ulcer, we give them a substitute to use. In terms of cholesterol, so There are tests to check the cholesterol level in the body, which is the lipid profile, which can be easily done by drawing up a blood sample. And then depending on the risk factor, so we look at a lot of things, the cholesterol level, the possibility of this person developing complications from it in the next 5 to 10 years. And we start cholesterol lowering medication based on that. So they are very safe medications with some side effects. There are no medications without side effects that can be used to lower cholesterol level, in addition to diet and exercise. So diet and exercise also cannot be overemphasized, okay, in its role in the reduction of cholesterol in the body. Then the very first question before I lost connection initially about people who don't have hypertension and end up having stroke. So like I said, there are so many risk factors. And if you remember the beginning of the presentation when I was talking about risk factors, I talked about modifiable and non-modifiable. So for the non-modifiable, increasing age, sex being male, race being black, there is nothing we can do about that. But there are so many things we can do, because most of the time it's a combination of all these factors that do result in development of stroke. So for the non-modifiable risk factors, those ones we can take care of in reducing the risk or development of stroke. I don't know if you're okay. Okay, so
yeah, thank you very much, sir.
Okay.
Okay.
Because I'm
There's
looking
another question on the chat that I want to take.
Yes. Is it possible to
Go
recover
ahead,
from
sir.
So the question states that, is it possible to recover from IBP and stop the use of BP drugs like Moduretic? So usually what I tell people is that hypertension or diabetes or asthma or any of these chronic conditions is not like malaria that you take drugs for 3 days and it goes away. No. However, the place of monitoring and follow-up is such that we are able to modify the dosage, add on new ones, remove old ones, depending on the individual. So blood pressure does not go away. Diabetes does not go away. They are lifelong. They can be controlled. And when you are diagnosed and placed on medication, you need to continue with follow-up so that your doctor at any given point can modify whatever treatment you are getting. Okay. I don't know if there's any other question that you'd like me to take.
Yeah. I can see two people here signifying. One is maybe Mr. Tom Ayegunle. Okay, could be Mrs. Patricia. Please, you can unmute and go ahead with your question, and then we'll take the last question from maybe Mr. or Mrs. Debo. Please unmute Mrs. Patricia. Okay, can we have Mr. or Mrs. Debo? Please unmute and go ahead with your question.
Hello, good morning, everyone.
Okay. Mrs.
I
Tuwashi.
just want, yes, please. Yes.
Okay.
I just want to remind us about our health insurance.
Oh, please unmute. You muted again.
I'm unmuted.
We are no longer hearing you. Please unmute, ma.
I'm unmuted.
Okay.
Yes,
Okay.
I want to remind
Go
us
ahead,
all.
please.
Okay, thank you. I want to remind us about our health insurance. The fact that we have retired does not mean we don't have access to it again. You go to LASMA office and they pay according to how you want to pay, maybe for yourself only or for yourself and 4 kids or whatever, the amount is still minimal. It's something affordable. So you can still, and I want to remind us that when we were on the health insurance while in service, everybody on health insurance, you are entitled to go to the hospital, the healthcare, your healthcare provider, that's the hospital where you are attached to, and do your normal health checkup. That is your BP, your cholesterol level, sugar level, HB1C. That's it. They want to know your sugar level in the past 6 months, your blood sugar, and several other, urine, what have you. So we are still entitled to it. When after I retired, I went there and told them I wish to continue. They said I still have 1 hour. I have a 1 year grace. That is, after retirement, you have 1 year of free treatment that you won't pay anything. So it's after that 1 year that you start paying. So that's what I just want to remind us. So about health insurance thing.
So thank you very much, Ma, for your contribution.
Thank
So
you.
let's have Dr. Oduwole back. Please unmute, Ma. I can see that you are signifying.
Yes, thank you very much for the opportunity. I just
And
want to,
that will be the last contribution we are taking.
I want to thank Dr. Ogundare again for the beautiful presentation. One thing I forgot to talk about, and which I would want him to enlighten us more, is the idea of detoxing or something, detoxifying. I know that when we were in the medical school, this was not in question. But nowadays, you find people going about with machines and so on. I would want to know your take on this and whether it affects or helps the blood pressure and cholesterol and so on. And again, please let us know that, like he said, we must take charge of all these things. They are not things that will come and go. They are things that you have to make sure you control very well. Thank you very much. Thank you.
So, Dr. Ogundare, please unmute, sir. Please unmute, sir.
Okay, I've been able to unmute myself now. Okay, so before I answer that last question, I saw something else interesting in the chat box, a question that, why do some people make full recovery and others don't? So that's dependent on so many factors. So it depends on, one, the age of the patient. It depends on the comorbidities. What other health issues the patients have been issued before development of stroke. It depends on the type of stroke. It also depends on the extent of the stroke. If you remember the images that I showed for the bleeding type of stroke, there was one that was very large and there was one that was smaller. That person with very large blood in the brain is not likely to do well in comparison to the person who had just a small area. Even the ischemic type that I showed, a small black area on one side and a very large black area on the other side. That person with a very large dark area also is not likely to make a full recovery compared to someone who has a very small area of the brain affected. Then the issue of detoxifying or and all of those things. So there is actually, like you said, Ma, even now for us in medical school now, there's nothing like that actually. And one thing I've come to realize is that I don't know if it's what is obtainable in other climes of the world. People believe more in a magic bullet. They want things that will make all their problems go away in an instant. There is no single cure for all diseases. There is no single machine that can make a diagnosis of all diseases at the same time. And so we have to understand and believe in our doctors a bit more. Okay, so if there is hypertension, there is no magic bullet to make it go away. If it's diabetes, there is, well, up until today, I stand corrected. I don't think there is any magic bullet anywhere in the world that will make it go away. But we can have it controlled and we can reduce the complications of these diseases and reduce the risk. Because if we control hypertension, if we control diabetes, like we keep saying, we reduce our alcohol consumption, we stop smoking, then we have a reduced risk of developing stroke. Thank you very much. Ma, I don't know if there's any question I left unattended.
Say again.
Any other question left out?
No, I don't think so. I think we have come to the end of the question and answer. Our time is far gone. Thank you very much, Dr. Ogundari, for your presentation and responses to all the questions. And I also want to appreciate everyone who has contributed in one way or the other. On that note, I would like to invite Dr. Femi Olubile, the president of Alausa. We want to hear his voice. Let him just do a wrap up for us on this issue. Please unmute, sir. Dr. Olubile.
Well, good morning, everybody.
Good morning, sir.
Well, and it's been a very rewarding and interesting presentation of a very interesting and important subject. It's something that should be of concern to everybody, especially as we get along the years. The presentation has been very succinctly put. The issue of stroke is an area of ongoing research, even as we speak, and the care of it is getting even more specialized. You'll have observed, some people have observed, for instance, that there's a specialized stroke unit that has been set up in Lasso. That is the trend. From just treating strokes as a general medical emergency, it's now taken as something where people have to acquire core knowledge. And then the issue of the window of survival, which is very narrow, the doctor talked about, I think he talked about 4.5 hours or something, is very important. Anything that is good for any stroke is an acute emergency, and to enhance the survival of anybody in that situation, things need to be put in within the window so as to optimize chances of recovery. I think everybody will have benefited from this immensely, and the questions that have been asked are very important ones too, and the responses have been appropriate. So I think it's been a rewarding morning of medical education. Some of the things that are also that have been suggested are ongoing wellness government intervention, maximizing the use of the clinic or the staff clinic of the Fodani clinic in the Secretariat should be taken out. A proper attitude focused on maintaining wellness rather than waiting to become ill is what is appropriate for civil servants to imbibe. And while the incident you described last week about the gentleman who passed on during the civil service week is very regrettable. It is not uncommon because that's how we are. That's because people often, it's a wake-up call for everybody to be very aware of their health status, to know their numbers, and to focus on the wellness approach rather than wait until they get here. So I want to say that it's been very useful, and I believe everybody should go away with some knowledge and an attitude change. Thank you.
Thank you very much, sir. Let me just stress what Dr. Olubile mentioned while he was talking. He said we should know our numbers. Please, let's make sure that we do our regular checks. That will help a lot to prevent that kind of medical condition and avoidable deaths. So on that note, let me just invite one of us to appreciate our facilitator for today. Please, you can signify, and then I will invite you to appreciate our facilitator before we round up. Okay, maybe I should just ask Dr. Olugbile to do it for us. Please do it for us, sir. Thank you very much, sir.
Well, okay. I want to appreciate the speaker, sorry, what's the name again?
Dr. Ogundare.
Dr. Ogundare, I want to appreciate Dr. Ogundare for the presentation that he has done. It's obvious it's fresh and young, and it's full of ideas and the latest knowledge, and it's always good to have younger people coming up refreshingly with cutting-edge information and sharing it with people who are further along the years. So so thank you, Dr. Ogundare, for this. I believe everybody has been suitably updated in their knowledge and influenced in their attitude. Thank you and have a very good day. I think maybe we can all unmute and clap for him.
Okay, let me just do it. So we can all unmute now. I've changed the setting. So let's do the clapping. Unmute and let's do the clapping.
Thank you very much. Thank you very much, everyone. Thank you.
All right. So thank you very much, sir, Dr. Olugbile. On that note, I want to, on behalf of the head of service, appreciate all of us for joining this call and also declare this webinar closed. Like we've already changed the setting. What we do normally on this program is to say hello to one another, people we've not seen in a while. Let us exchange pleasantries before we finally end the meeting. Thank you all for joining. God bless you.
Hello.
God bless you, sir.
So much.
God bless you,
Mrs.
Dodola.
Thank you very much.
Thank you
You are welcome. You are welcome.
We appreciate you.
Yes.
You are welcome, sir.
That's
God
cool.
bless you, everyone.
Amen. Oh, thank you. Good to see
Thank
you,
you,
Mrs.
Dr. Oluwole
Toluwale.
and Dr. Olugbile for your contribution.
Good morning.
Mrs. D. Mrs. D for them.
Have you? Have you?
Olúwa ló ń tọ́jú gbogbo wa mà.
Our mommy.
Wọ́n tọ́jú gbogbo wa.
Our mommy.
Yes, God bless you.
Oh.
Thank you very much.
We appreciate
More
you every time.
wisdom to our facilitator.
Amen.
Thank you very much.
Thank you.
Bless you.
You're welcome, ma'am.
Mrs. Kolawole Ekabo, you are welcome.
Eshema. I came in late.
Good
morning.
This is Mrs.
Masato. I came in late as well.
Thank you very much for joining, ma. God bless you.
It's all right. It's all right. I know you send the recorded version to us. Thank you so much.
I will. Yes, we can always go back to it.
Okay.
Let's subscribe to that YouTube channel.
Okay.
So that we can also get notifications, and then we can then go back to it all the time to revisit all these lectures. Thank you very much. So I will send the link to us.
Well done, madam. Well done, my sister. God bless. Okay.
Thank you. Thank you,
ma'am.
You're welcome.
Yes.
So on that note, I'm going to end this meeting until another 2 weeks.
Yes,
We are
of course.
talking business in the next 2 weeks, and we are looking at exports. I'm
Okay.
sure we want to earn some hard currencies. So we are
Oh,
going to
yes,
learn
yes,
how we are going to do it in the next 2 weeks. Ensure that you are
Okay, man. God willing.
Amen.
Yes.
That will be very nice. Thank you and well done for a good job.
Excellent.
Hey, Mike, how are you doing now? I did. Well done. Bless